my name is Sophie Washer. I am a fourth-year radiology resident from NYU. It is my pleasure to introduce Dr. Nix Kumarevel, who is our musculoskeletal deputy editor. He'll be showing cases for you.
Thank you, Sophie, and welcome to the musculoskeletal section of the case collection. So here's the first case. If we can advance the slide. Can we get to the next slide, please? Thank you. And so the first case we're presenting is a 28-year-old man who reports progressive swelling in the posterior aspect of his knee without any known significant medical history otherwise. The patient is pretty well presenting to us with just a lump. What do you think about this? Give you maybe a second to look at the radiographs to start with. And we got some cross-sectional imaging coming up in a moment. And will we go to the next slide, please? And here are some T1 and fat saturated T2 images for you. We got some axials, we got a sagittal, and we want you to think about this and say, what would be the possible diagnosis for this condition? Give you another couple of seconds to look at it, get your thoughts together. You can go to the next slide, please. And so what do you think is a diagnosis in this scenario? Is it parosteal osteosarcoma? Do you think it's a sessile osteosarcoma? Do we think it's myositis ossificans? Or do you think it's a periosteal osteosarcoma? And go to the next slide, please. And start voting now, please. All right. Give it another couple of seconds. All right, so if we go to the next slide, please. Excuse me. So the diagnosis is going to be parosteal osteosarcoma. We can see these images again. If we go to the next slide, please, again. And the reason for this diagnosis is more apparent when you start diving into the individual components of it. So it's a dense mineralized, just as juxtacortical lobular mass as such. You can see that it's actually the posterior metaphyseal junction around here with eccentric stock coming off it. You can see these little fat extrusions in between where the errors are. It tells you that the lack of perpendicular periosteal reaction is what is distinguishing this to become a parosteal osteosarcoma. Thank you for looking at that. If you go to the next case, please. In case 2, we have a patient presenting with progressively worsening ankle pain for about 5 to 6 months. The patient noticed at the end of the working day, this is not allowing her to stand up or walk for a long period of time. The pain is now rated about 10 out of 10. And she did have a history of ankle sprain about 18 years ago. But other than that, there's no new injuries for this event. Let's start with the radiograph. Here's the radiograph, presenting radiograph. Worsening ankle pain. We go to the next slide, please. We got a couple of axial images for you. And I want you to think about what could be the causing this patient's ankle pain. And I'll give you another second to look at it. And move on to the next slide, please. Here are some more coronal images, and we're trying to focus your attention to try and give you some choices of thinking what could be the cause of ankle pain. And if you go to the next slide, please. And there's a couple of sagittal images again through the region of interest. Just to let you know, we're now on the lateral side of the ankle, as you can see. And go to the next slide, please. And what do you think is a diagnosis given these constellation of stuff together? Do you think it's a peroneus brevis split tear? Do you think it's a peroneus brevis just tendinosis? Do you think it's a peroneus longus tendon tear? Or do you think it's peroneus brevis tenus synovitis? And let's go to the next slide, please. So based on all this, what would you think your diagnosis is? Please go ahead and vote. All right. Give you some more time. Fantastic. Thank you very much for playing on. Let's move on and let's find the answer. And move to the next slide, please. The answer is peroneus brevis split tear. And that is a reason why this patient's got pain. And if you go to the next slide, please. So when you think about the peroneus brevis tendon, I mean, we all know that the peroneus brevis tendon is the one that's closest to the bone, and the way I remember them is B and B to go together, so bone and the brevis tendon close together. It's a common cause of lateral ankle pain, as you know. The most common type of peroneus brevis tear is a longitudinal tear that goes down, and that's what we're seeing here as well. And this is due to repeated compression by the peroneus longus tendon, which lies on top of it, and it jams it between the two, the lateral malleolus and the peroneus longus tendon. The MRI demonstrates a torn tendon in this situation, and what you want to know is how far is the split and where is it going. You end up with two hemitendons, and that gives you this sign, which is called the boomerang sign, or a C-shaped sign, which is where you get this little hyperdensity in between that's coming along between the two tendons. So that's the diagnosis. So it's peroneus brevis tendon. Thanks very much for playing along, and I hope you'll be interested in looking at more cases in the RSNA case collection. We have lots of them for you. I would pass on to the next speaker. Thank you again for the opportunity.
Dr. Vicini again. Now I'm pleased to introduce Dr. Cinzia Vu, Assistant Professor of Radiology at Emory University and our Neuroradiology Deputy Editor, who will be presenting our interesting cases. Please, Dr. Vu.
Thank you so much for that introduction. We'll go right into our cases, please. I will. Thank you. So our first case is a 43-year-old man who presented with a gradual and also insidious onset of vertical diplopia over the past 8 months, and it's best relieved by covering his left eye. He didn't have any trauma to that eye, nor any similar complaints to the past, but this slow developing diplopia. So I would encourage you to think about what may cause issues with extraocular movements as you look through these first images. Mostly through the brain, as you can see pre-contrast and post-contrast T1 weighted images, as well as coronal and sagittal reformats through the area of interest. We have the next slide, please. Oh, so here we have additional images highlighting the area of interest, an axial T2 weighted image, as well as a axial CTA image. And you may notice that on the CTA image, the area of interest is highlighted and demonstrates relatively less enhancement than the vessels seen here. So take a moment, take a look at that. Think about what this may be, and we'll go to the next slide. So what is the diagnosis? Is this an aberrant vessel? Is this a meningioma? Is this demyelinating disease, or is this a trochlear schwannoma? And again, think about the patient's symptomatology and look at these images, and let's take a vote. Oh, so okay. All right, so it looks like folks are settling in here. And indeed, the trochlear schwannoma here is the right answer. We notice that this does not have the same enhancement characteristics as the vasculature around it, so it's much less likely to be an aberrant vessel. This is not a meningioma, it's sitting in the cisternal space, and it is also not demyelinating disease because it's not a parenchymal lesion. So indeed, trochlear schwannoma is the right answer. When we look at a patient with diplopia, we must think about what muscles and nerves may cause that to happen. And here we're thinking about the cranial nerves that are supplying the extraocular muscles, which would be cranial nerves 3, 4, and 6. Cranial nerve 4, trochlear nerve, is a very small nerve that courses in the ambient cistern, shown here, after exiting the brainstem and decussating. And again, it's such a small nerve, and usually you don't even see it on your routine MR imaging. So if you're not suspecting a lesion in the site, it's almost impossible to pick up something right here, right? So it's important to know the history, and it's important to look in the right area when the history points you towards an extraocular movement problem. And again, in this case, the slow onset of the patient's symptoms, as well as this abnormal nodular enhancement in the region where you would expect the trochlear nerve to course, is helpful in identifying the pathology. All right, so we'll move right on into case 2. And this is a 64-year-old woman who has a past medical history of multiple myeloma, and this is an important point. And she presented to the ER with a more acute onset right-sided mandibular pain that resulted in multiple visits to the ED in the past year, but it got quite a bit worse just now. There's associated swelling as well as purulent bloody discharge from her right jaw, which began after a dental appointment. So you'll see on plain films, there are some distinct abnormalities with her osseous structures. Here are additional views of those abnormalities on CT, axial, and coronal images. And here we have images that are more relevant to the question at hand, which is her right jaw pain. So axial, coronal, sagittal reformats. And on soft tissue windows, you may also appreciate some associated soft tissue abnormality against that region of osseous abnormality in the right jaw. So keeping our patient's history of multiple myeloma in mind, what is the diagnosis here pertaining to that right jaw? Is this a primary malignancy of the oral cavity? Is this osseous metastasis with a pathologic fracture? Is this medication-related osteonecrosis of the jaw? Or is this osteoradial necrosis? Again, remember that she has a history of multiple myeloma. So we'll take some votes. All right. Oh, a little bit of a back and forth there, but I think we're settling in, so we'll move right along. So this indeed is medication-related osteonecrosis of the jaw. And you can see that the mandible here has these very irregular lytic lesions. There is also a pathologic fracture associated with it as well. But this case is actually one that is fairly driven by the history. We all know that bisphosphonate use can increase the risk of osteonecrosis, and bisphosphonates are often used in multiple myeloma, often to prevent fractures, but sometimes it can induce osteonecrosis, medication-related osteonecrosis that can result in a fracture as seen in this case. We have this mixed lytic and sclerotic appearance of the mandible. You see the change throughout the mandibular body. We have a chronic appearing displaced fracture. And then there's also this irregular periosteal reaction arising from the edge of the bony cortex. As we suspect, these imaging findings can overlap with findings of osteoradial necrosis as well as osteomyelitis. As you can see, there's also a good amount of soft tissue abnormality surrounding the jaw here. So our history is very important in this case in accurately diagnosing medication-related osteonecrosis. And another piece of history that's helpful to keep in mind is that often the patient already has a weakened bone structures, if you will, and this can be exacerbated by dental procedures, as in the case of this patient. Additionally, in this case, you do see these multiple punch-out lesions in the calvarium and throughout her bony structures, in keeping with her history of multiple myeloma. So, thanks for playing, and leave it to the next speaker.
Hi, Megan Mercer again, resident at MUSC. I'm here to introduce Dr. Saeed El-Ajami, also from Medical University of South Carolina. He is our nuclear medicine deputy editor and will be going over some cases with us.
Thank you, Megan, for this introduction, and hello, everyone. So let's go ahead and start with Nuke's case number 1. So this is a 16-year-old with Hodgkin lymphoma who presented for follow-up PET CT scan 6 months after treatment. On the left, we have a coronal body maximum intensity projection, FTG PET CT image. And on the right, we have a coronal fused PET CT image of the body. These are additional axial fused images which are shown on top. with corresponding non-contrast CT images on the bottom, obtained at the level of the shoulders, chest, and upper abdomen. So based on these images, what's the likely diagnosis? Is it 1, lymphoma, 2, muscular uptake, or 3, brown adipose tissue? So go ahead and answer your answers. So the correct diagnosis is brown adipose tissue. So what we're looking at here are foci of increased activity on PET with corresponding fat attenuation on CT. With lymphoma, some of you had answered lymphoma. With lymphoma, we expect the activity to be associated with enlarged lymph nodes. And with muscular uptake, similarly, we expect the activity to correspond to the muscle. So brown fat adipose tissue appears on PET as foci of increased hypermetabolic activity with corresponding fat attenuation on CT. Brown fat uptake is physiologic, and it's commonly associated with cold in young and skinny patients, and usually shows symmetric and bilateral distribution in the neck, chest, and upper abdomen. Rarely it may be asymmetric. Brown fat FTG uptake may be reduced on future scans by using warm-up blankets to the patient or by pre-treating the patient with beta blockers such as propranolol. Let's move to case number 2. This is a 68-year-old female with history of multiple myeloma. We have here an axial attenuation correction PET image, axial fused image, as well as a contrast enhanced CT image of the abdomen. Based on the findings, what is the likely diagnosis? Is this gallbladder malignancy, gallbladder metastasis, physiologic FTG, or chronic polycystitis? Go ahead and answer your answers. So majority have answered physiologic, and some of you have answered chronic cholecystitis. So let's go over that. So the correct diagnosis is physiologic biliary excretion of FTG. So radiotracer localization, if you notice here, it's inside the gallbladder lumen. In the absence of suspicious abnormality on CT, we don't see any wall thickening. It's rarely seen on PET CT imaging, and it's related to vicarious excretion of FTG into the gallbladder. And this should be recognized as a normal and incidental finding and should not be confused with pathology. In cholecystitis, radiotracer activity will be associated with the gallbladder wall, and there is usually evidence of gallbladder wall thickening. So you would see the activity inside the wall, and you would see gallbladder wall thickening or edema on CT. In gallbladder malignancy or metastasis, activity is usually focal, and there will be evidence of a gallbladder nodule or mass, as well as wall thickening on CT. Excellent job, everyone. So this is the end of the Nukes cases.
I'd like to introduce Dr. Catherine Phillips, who is Assistant Professor of Abdominal Imaging at Vanderbilt University, and who will be introducing some wonderful cases in obstetrics and gynecology.
Thank you so much for that kind introduction. We'll go ahead and get started. So here's our first case. This is a 45-year-old woman who's coming in with 3 months of irregular menses and pelvic pain. Of note, she does have a past medical history of a lumpectomy for breast cancer approximately 3 years prior to presentation, for which she's been subsequently treated with tamoxifen. Here you have grayscale, sagittal, transverse, and sagittal oblique images through the uterus. Take a moment and look at those. The next here is a few more images both with color and spectral Doppler, demonstrating some further interrogation of those findings we saw in grayscale. And so what's the diagnosis? Are these submucosal fibroids, endometrial carcinoma, endometrial hyperplasia, or endometrial polyps? Great. You have a few more minutes to get your answers in. It looks like we're reaching consensus here. So yes, the diagnosis here is endometrial polyps. And what you're seeing on grayscale ultrasound as well as color Doppler are these well-defined, predominantly hyperechoic intraluminal masses within the endometrial canal. They do typically, when large, especially in this case, show internal vascularity as a stalk, which is when interrogated with spectral Doppler will demonstrate arterial waveforms. Of note in this case, there's no junctional zoma regularity seen to suggest myometrial invasion in the setting of a carcinoma. And of note, there are some technical limitations, in which cases you would not see internal vascularity within these lesions, namely if the polyps are very small, if there's poor sonographic technique, where the color scale is not dropped all the way down to determine slow flow, or if the polyp has infarcted. Great job. Case number 2. Here, this is a 67-year-old nulliparous postmenopausal woman presenting to an outpatient clinic with fecal vaginal discharge for approximately 1 month. Here you have midline transabdominal grayscale imaging through the pelvis. And here is also midline sagittal grayscale image through the level of the uterus. As with ultrasound, it's frequently helpful to have RSNA clips. So here is a representative sagittal color Doppler or grayscale ultrasound clip through the level of the uterus. Attention to this area. And subsequently, this patient underwent both a IV and oral contrast enhanced CT. Here we have a representative coronal clip. Draw your attention down to the left lower quadrant. Great. And we're going to have some representative still coronal images from that series. Great. Okay. So with all that in mind, what is the diagnosis? Is this colonic endometriosis with a coluterine fistula? Is it colonic diverticulitis with a coluterine fistula? Is it colorectal carcinoma with a fistula, or inflammatory bowel disease resulting in that coluterine fistula? Great. There's a little bit of a split. A few more seconds to get your votes in. Great. Looks like we've reached consensus. And exactly, this is colonic diverticulitis with a coluterine fistula. And so as you can see, based on ultrasound, with this markedly echogenic material with posterior acoustic dirty shadowing, which represents air. You see it both on transabdominal and transvaginal exam, as well as on CT, you can see communication of that enteric contrast material between the adjacent lupus sigmoid colon and the uterine canal. Here, you see direct communication. Although there is enteric inflammatory changes on CT, there is preservation of the typical mucosal fold, which leads you away from that inflammatory bowel disease. The presence of multiple colonic diverticula and the history of fecal and vaginal discharge clinches the diagnosis. This is in fact diverticulitis resulting in a fistula. And with that, I thank you for your attention, and I'll give it over to the next speaker.
I would like to introduce Dr. Mary Wires, who is assistant editor for the case collection and associate professor of radiology at Northwestern University.
Thank you for that introduction. So we'll move on to some pediatric cases. Okay, first case. This is a 4-month-old boy who presents with left lower extremity pain, erythema, and swelling at the level of the calf that has worsened over the past 2 weeks. And hopefully you can hear me okay. So I'll just draw your attention to the lateral parts of the ribs along the chest wall here on the left and on the right. And then here we also have an AP view of the skull and AP and lateral views of the tibia and fibula, demonstrating some thickening here around the tibia and fibula, which is very dense and sclerotic, as well as along the left side of the mandible here. So what is the diagnosis? Do you think this is physiologic periostitis, rickets, Cathes disease, or non-accidental trauma? So go ahead and vote. Okay, good. So most people thought this was Cathes disease. I can't advance the slide. Thank you. So that is the correct answer, Cathes disease, also known as infantile cortical hyperostosis. So Cathes disease typically affects very young infants, usually before the age of 7 months, and presents with focal soft tissue swelling, erythema, and pain. And you can see the arrows on some of the findings here along the lateral ribs, the hyperostosis along the long bones. In this case, it was the tibia and fibula, and the mandible is often characteristically involved as well. It may be bilateral, but is often asymmetric. And moving on to the second case. So this was a 6-month-old boy born full term, no significant past medical history. He presented to the emergency department with shortness of breath, failure to thrive, and hypoxia. And we have frontal and lateral views of the chest. And you can see that there's lucency in the left chest and the heart is shifted over to the right. And it looks more anterior on the lateral view. And on the CT scan, we see similar findings. I'll give you a second just to look at the CT findings here, and then we'll have a question. So again, you can see the abnormality here in the left lung and the shift of the mediastinal structures to the right. So what do you think is the diagnosis? Is it bronchial obstruction, pleural pulmonary blastoma type 1, congenital pulmonary airway malformation, or congenital lobar overinflation? So go ahead and vote about what you think the diagnosis is. Okay, so we're kind of split between these three here. Most people thinking this is a CPAM. So we'll go on. And the diagnosis is actually pleural pulmonary blastoma type 1. You can see that this is mostly a cystic lesion This is definitely in the differential, however, and we have a hard time telling the difference between these two choices in clinical practice on a routine basis. So if you picked 3, you're in good company. So pleural pulmonary blastoma is a malignant lesion of the lung. Type 1 is the predominantly multicystic type. So this is the one that we have a hard time telling the difference between this and a CPAM. Most of these patients present very young in the first year of life. The other types of pleural pulmonary blastoma, types 2 and 3, have solid components. And so those are usually a little easier to tell that you're dealing with a malignant lesion. The importance of this entity is that it has an association with the DICER1 gene mutation, and this is a cancer predisposition syndrome. So these patients may develop other cancers throughout their lifetime, and they need to be aware of that. And that is all for me.